Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning. Thank you for joining us for this edition of Ethical Perspectives on the News. I'm your moderator, Lynda Waddington. I'm also a columnist at the Gazette. This morning we're going to be talking about mental health in Iowa. It's a subject that's been in the news for quite some time. And for those of you who aren't familiar, I want to read you just a few short statistics. So nationally, 1 in 4 Americans will have to seek behavioral health care services at some point in their life. Iowa currently has about half the number of psychiatric beds that they need to care for the individuals in our state who need that service. An estimated 80,000 Iowa youth have some sort of severe psychiatric disorder. Now nationally, there's been a move to deinstitutionalize mental health care services. And in Iowa, this is true as well. For instance, our 4 mental health institutes at one point served about 1,700 people every month. That number as of 2012 was down by about 750 people. The question is, even as we move toward a more community-based service, are we still providing people the care that they need? So I have a terrific panel today. I'm so happy you get to hear from all of them. Immediately to my left, we have Lynn County Supervisor Ben Rogers.
Good morning.
And to his left is Rosemary Ziskovsky, Clinical Director at Horizons. Good to see you, Rosemary.
Good to see you too.
And on the far left, we have Dan Strellner, who's President of Abbey Incorporated.
Morning.
I'm so happy you all are here so we can talk. One of the things, we are moving toward a new mental health care service. Can any of you tell me what the ideal is? What are we moving toward? What do you think it's going to look like in 20 years, 25 years, where we get to where we want to be? You want to start?
Well, that's a tall order. In an ideal world, mental health care would be treated and provided on par with how you receive just regular health care. And by that I mean, if you're an individual who has a psychotic episode and you need to receive services and you go to the emergency room, oftentimes you don't see the doctor right away. You may spend several days in the emergency room, which is not the appropriate place to receive those kind of services. And then if you are able to see a psychiatrist, or if you are able to get a bed, it may not even be in the community in which you live. This is very different from how, let's say, someone has a heart attack. They go to the emergency room, then they're moved to a more secure setting where they see a cardiologist, and then there's nurses and their family doctor, and the whole hospital almost seems to support them, and they're not released until really they're safe to go home. That is not the case for people with mental illness who have great difficulties in managing that. And so hopefully in the next 20, 25 years, hopefully well before then, that there is parity between how you receive your health care and then your mental health care.
We have had this discussion as a nation about health care. It's been discussed, it's been rediscussed. We have new health care reform at the federal level, but we still haven't gotten to the point where mental health is a part of those core services. Can we reach where we need to be with mental health care services if that doesn't happen?
Well, I think that I absolutely echo what Ben is saying in terms of just our culture's attitudes about mental health. So my vision is hopefully in 20 years we have much more of an understanding of mental health is as critical and important to treat as physical health. And I think that when culturally we're all ready to go in that direction, we'll be ready to make that a priority. And priority legislatively, priority with appropriations, priority even as a community to say, this is something we need to be focusing our energy on. And these are folks who have great need, and it's our responsibility as a nation, as a state, as a community to support people so they can get well. And the tragic thing is, these are treatable conditions. This delay in treatment is causing more crisis situations, is causing more burden on the state because you need a greater level, intensity of service when there is help proven, evidence-based help to do some early intervention and to get people on the right track for recovery.
So Dan, if all this is true and these are treatable conditions, then why do we have such prevalence? I mean, are people not seeking services, or the services just not there?
Oh, I think it's a combination. I think we can get there. I don't think we can afford not to get there and integrate behavioral health into our overall healthcare system. On average, individuals with a serious mental illness die approximately 20 years younger than the rest of the population. Wow. And that's primarily due to treatable conditions, as Rosemary indicated, things like diabetes, hypertension, cardiac disease. And a lot of the folks we work with a chronic mental illness have not really had any primary care for years. For a variety of reasons. They're busy managing their own lives, there's poverty involved, there may be homelessness involved, all kinds of other things in their lives, so that finding a doctor until it's absolutely a traumatic situation or a crisis isn't high on their list sometimes. So they end up at the emergency room as their primary care physician. With the advent of integrated health homes and even managed care, which I assume we'll be talking about soon, can help us get there, I think, so that we start talking, as Ben related earlier, about mental health as health care, not mental health.
Now we are seeing that national move toward more community-based care. Is that the be-all and the end-all? Eventually, will the state not need to operate psychiatric beds? Is community-based going to serve everyone at every time?
I can start with that because I think no. I think there is no be-all, end-all. I think most of us would agree that the whole idea of deinstitutionalization and people living in the community is the right thing to do for those folks who can. In fact, the majority of folks with a serious mental illness do live in the community with a variety of service, different intensity levels, et cetera. But that doesn't do away with the need for inpatient psychiatric beds. Acute episodes many times result in a psychiatric hospitalization on a local inpatient unit, for example, for a period of time, and then maybe a placement at a residential treatment center for a time after that, as a person gets used to new medications and just the trauma that goes along with a psychotic episode, for example. It's really as traumatic for a family as a heart attack or a diagnosis of cancer, for example. And it certainly doesn't mean, because we're looking at maybe downsizing some MHIs, that level of service isn't needed. People don't become well just because we close facilities.
I actually wanted to move over and talk about those current events that have been happening. It made headlines when Governor Branstad decided that he was going to reduce funding for 2 of the 4 states' mental health institutes. So he's looking at closing Mount Pleasant and Clarinda. And as we know, each of those 4 institutions had specialized care. When Governor Branstad has met with us as the Gazette's editorial board, he said the 2 institutions he plans to close were not accredited and that they were having trouble meeting staffing requirements, that they couldn't bring those professionals into Iowa. But he also has told us that he believes the people being served by those institutions now can be absorbed into community-based private care. Does Iowa have that now? Do we have enough beds? Do we have enough providers to care for those individuals now being cared for at the MHIs?
I think in your opening remarks about the number of people who used to be served, that 1,700, that's now been reduced down to probably under 1,000. We don't have enough beds. And in fact, almost every provider and mental health advocate says we need more beds and we need more psychiatrists. And so having less in the system will put a greater pressure on providers of services and then providers of services like the county. And we're already starting to see that the safety net is starting to kind of be frayed. And so now we're going to put more pressure on that net by closing those facilities and saying, okay, counties, okay, providers, you take them. And we may not be that equipped, or there may not be the long-term kind of funding that would allow providers to be able to either ramp up services or help collaborate with other providers to ensure that that person's needs are being met and that they're not being put into a situation that could either cause them harm or the community harm.
Yeah, and I, would add to that, maybe down the road, it is more efficient to look at changes in how we support institutions like at Clarinda or at Mount Pleasant, but the lack of preparation to see, do we have the resources needed? Do people have the training? These are very specialized populations that I understand that there's space like at MHI, but you can't just move people with very particular psychiatric medical needs and put them in beds and assume they're going to get the care that they need. So it just seems like there needs to be a lot more conversation with the consumers who are impacted, their families, the providers that are being asked to provide this service, to say what resources do we have? Are they available? Are they only available in our metro areas? Or are they available in the communities in which we're moving folks? How far are people going to have to travel now? And if the need isn't met here, what's available elsewhere? But that's adding other hardships and other layers to have the support system some of these folks have even further away to do that. So it just feels like you need planning to create stability and predictability that we are going to offer high quality services. And of course, that's what every provider is their goal to do, is what's the highest quality client-centered services that we can provide. And this puts providers in a very difficult situation. They'll step up, but it's not in an ideal, or not even close to an ideal. It's not putting the client's needs as front and center.
And my understanding of the state mental health institutes was that they were often placements of last resort. So these were individuals, for instance, Clinda ran the geriatric unit. So these were individuals who had tried traditional nursing homes, who had tried living at home with their families, who had gone through all these different steps, including private care. And this was it. This was the last place that they could find within the state that these people could get the treatment that they needed. What happens to that population? Do we now have, providers who are willing to take them on? Or are we looking at out-of-state placements? What are we looking at?
I think probably some of all. I think one of the things that happens when we downsize facilities like this is we lose a treatment option. First of all, for that level of intensity of those folks, a small percentage of the population that are seriously mentally ill require a real intensive 24-hour supervised kind of setting. Not only for their safety, but also for public safety at times, because their illnesses may be so severe, or their illnesses may be medication resistant, that it's just not having the impact that it would with some other folks. So I think, yeah, there are providers who are willing to try. I think one of the unfortunate things that happens, though, is that many times when we close a public-funded facility like this, if you will, the funding that was going toward that facility doesn't go with the population that moves. In fact, it doesn't even stay in the mental health system sometimes. It may go to the bottom line in the budget, so we may lose another $10, $15, $20 million out of mental health by closing a facility, which seems kind of backwards to me when we're asking folks to serve these individuals in the community.
And Ben, you were talking a little bit about the planning, and I know that you and I have talked other times about options of Lynn County and the changes that are happening with sheltered workshops. And one of the things there that I keep hearing from everyone involved is they have the time. They have the opportunity to plan it,
right.
and it doesn't feel as scary as it might because of that. Can you speak a little bit about that?
Well, Options of Lynn County is a very specific program for people with disabilities, and we were able to anticipate that there was going to be changes in the federal laws with regards to the Olmstead Act, which says that people with individuals with disabilities should have a choice in the kind of services that they receive, and where they receive that should be in a less restrictive environment. So Options didn't meet those federal guidelines, and so we have about 1.5 years of planning until we know when that drop dead date is. And so now parents and family members and advocates can all work with other providers to make sure that the person receiving the service doesn't even feel the interruption, even though that the program will end. And so while parents and family members are upset that Options is closing, I think they've taken a lot of comfort that there has been almost 1 year's worth of discussion on how to transition the program, and then once the decision was made that it needs to end in the June 30th of 2016, how we're working with other providers and other area members to ensure that this population is taken care of, I think has been a great source of comfort. that kind of conversation has not happened with the closure of these institutions. They're closing, and what I get asked most often is, do we track these people? Do we know where they go? When we downsized or when the Abbey Center had to close, do we know where these people go? Well, they go a lot of other places in the state. They may not be here in Cedar Rapids. They may end up in jail. Our jails, our county jails in particular, the numbers of people with mental illness and substance abuse issues are rising significantly. And so we're doing a disservice by not having that additional tool in the toolbox of a state facility that really helps those that are in crisis and those whose illness doesn't allow them to live in the community.
And that was actually the focus of the Mount Pleasant facility, was that dual diagnosis of substance abuse and mental health issues. So without that, does everyone here agree at least a portion of the people that might have been served or that were previously served will end up in our correctional facilities?
I think we can assume that based on what we know and the statistics we know. In fact, there are some policymakers on both coasts now who are investigating actually increasing the number of beds versus downsizing, because as they term it, we're basically, by deinstitutionalization and not being ready for it with community planning, what we've really done is trade in good inpatient psychiatric treatment for warehousing in jails and prisons.
Another thing that's been in the news lately is that Governor Branstad has decided that the state of Iowa is going to move to managed care. How does that impact, especially you two, how does that impact what you're doing with mental health services?
Well, behavioral health has been under managed care for quite a few years through Magellan, so the managed care model isn't necessarily foreign to behavioral health. This will include all of Medicaid services, and it's including in behavioral health too, like all the waiver programs, residential programs. It's pretty widespread in terms of who it's going to cover. I think there's a lot of questions at this point. You know, who's going to be included in the network? What are the reimbursements rates going to be? Will clients, you know, how will they be transitioned to knowing what's the best choice for them and making sure that's all goes smooth for them? The biggest concern I have about the managed care, I'm kind of open-minded as to, well, that may be a better option, you know, in terms of having multiple vendors and choices, that sort of thing. But it doesn't, again, it felt like it was very sudden, very quick. It's on a very aggressive timeline. So while they've had some opportunities for public conversation, it felt like I heard about it. Those public conversations were had, and oh my goodness, you know, I didn't get to that, you know, and not that there wouldn't still be opportunities, but I can't see where the oversight to this huge system over, what is it, billions of dollars of a program, and so I know there's others that share that concern that there needs to be some kind of oversight to this new system, and there's just a lot of questions, a lot of unknowns.
Yeah, it's $4.2 billion.
$4.2 billion. Okay, I knew it was
close to
4
600,000
something.
people.
It's a big number.
It is, and I think we're about to experience over the next 2 or 3 years probably the largest change in how healthcare is delivered to our Medicaid population that we've experienced in Iowa. And managed care, you know, it's not a bad thing in and of itself. The ideals of managing an illness and managing a person's total illness and total health care is a good thing in general. I think it can bring some positives in that hopefully it can reduce some redundancies and really provide more coordinated services. On the other hand, as a provider and an advocate, I get concerned about whether access will be reduced at some point. We have a $200 million Medicaid deficit in Iowa right now, and managed care is charged with helping us deal with that. So obviously we get concerned about how that's going to be realized.
One really good thing I think that's come out of the legislative session is some software that's being developed. Believe it or not, well, you guys already know this, but to the audience, believe it or not, in Iowa, we did not know at any given time how many psychiatric beds were available. So when someone showed up in an emergency room and needed a psychiatric bed, it was a very manual process of a nurse or a practitioner getting on the phone and calling around to see who had a bed available. So the legislature has put some money to good use and said, you know, this should be automated. We should be able to look at a database and know when we have beds. So the larger question, I think, is once we know this, will it bring home the fact that we are way under-bedded in Iowa?
Well, we already know we're underbedded in Iowa. So, I mean, obviously that's a great system and will create, hopefully, quicker access for people. But the reality is still, even if you have quick access to all that information, if there are no beds to be found, you're still stuck in the same situation of where are we going to put this person, where's the best care, and as Ben said at the very beginning of the program, you know, emergency rooms now become the place, and I was reading an article where they are having some permanent rooms in emergency rooms that they've accepted are going to be for psychiatric patients because that's what the reality of what's happening. And again, as I said, people do what they can to make the best out of a situation, but we want better, and our community members deserve better. So the bed problem is still a problem.
You know, and I have spoken with some parents who, you know, had a horrible acute situation. They wound up in the emergency room and had no understanding of kind of the shortage that's happening in Iowa, not only with finding beds, but with finding providers, how far they might need to travel to access that provider once they found him or her, and especially those who lived outside of metro areas. So we know that we have this shortage. We know that there have been some incentives, tuition reimbursements. I'm not sure what else was out there. But what else can our rural areas do to entice those professionals?
Well, I know the legislature has tried to deal with that on a couple of different fronts. There are some federal funds available for rural areas to apply for if you're in a medical health care shortage area to help entice physicians, psychiatrists, et cetera. I think we need some state funding to help address the issue. We proposed that to the legislature. I don't think it's going anywhere this year, but we'll keep after it. It's not only a shortage in rural areas, and I certainly understand that. There are shortages of psychiatrists in the urban areas of Iowa as well. And the urban areas don't qualify for those federal funds because we're not in a healthcare shortage area. Between Lynn and Johnson County, we probably have the most psychiatrists in the state concentrated, but many of those are at the University of Iowa who don't practice in the community. And so it's skewed when people look at psychiatry availability in these two counties, for example. I'm very much a supporter for loan repayment, stipends, et cetera, whatever it takes to attract physicians, physician's assistants, nurse practitioners who want to specialize in mental health to come and to stay in Iowa.
And if we bring these individuals to our state, and we still have this shortage of beds. I keep going back to this whole bed shortage and professional shortage because I just don't quite understand it. We have a good quality of life in Iowa. You know, by and large, it's a great place to live. People want to come here and raise their families. Plus, we have first of the nation politics. And what's not to like about that except the advertising? So, you know, are we just not reimbursing for psychiatric treatment? You know, are we not reimbursing providers where we need to? Are we not offering the pay scales that we need to attract the professionals? You know, is part of that an issue?
Yes, I think I think you could make a case for almost all three. That again, there is a deficit in the number of psychiatrists that we need to assist the population that's already here. There's an issue of retaining and attracting people, particularly in the rural communities. And I just spoke with a woman who called me. She was actually at our library presentation and just moved here from Pennsylvania, lives in Jones County, is having mental health issues, has had mental health issues, doesn't know where to turn. I gave her a number to call, but they don't really have services out there. And so we moved to a regional system to try and address these problems that no matter where you live, there is a certain level of service. But if you don't have transportation to get there, if you don't have the ability to change your schedule, then this whole system is really built not for nothing, but it makes it so much more difficult for people to receive those services.
And what about telemedicine? You know, we've heard a lot of promising, you know, that it might be able to fill these gaps. Are we utilizing it now?
Well, I think it's being used in a variety of ways. I know that Abby has been using it for some of the rural locations. I know the region had just approved some funds to support that kind of service throughout the region, and especially in the rural areas. I know that Unity Point is using some telehealth at the panel we were at. Ken Jackson had mentioned that. And when you read the literature, honestly, that's the way it's going in the future because of all these barriers, whether it's transportation, whether it's cultural preferences. My daughter's generation would much rather sit and do a Skyping appointment with a doctor than to go face-to-face in the office. So even consumer preference along with accessibility is going in a direction. And, you know, the laws are behind. So you have HIPAA laws that are trying to catch up with that so that we're assuring confidentiality and that sort of thing. I would have been a skeptic initially because I'm a therapist and I think that face-to-face, but I read research on it and it's proving to be quite effective for many people. And the bottom line is, how can we make this accessible for people who need help? And that's the most important thing. So if it can be effective and bring services to more people, especially in our rural areas, I'm all for it. But funding's an issue. They pay for one side of it, but not the other side of it, meaning the doctor providing the services is going to get reimbursed. The professional who is helping with the other side of it, there's no reimbursement. And I understood Representative Heaton say that they were looking at legislation to try to pay both sides of that. So reimbursement is an issue in terms of being able to provide the service that's needed, but also to be able to stay afloat, whether it's a region or a private practitioner or a community mental health center.
You know, this is a crazy complicated issue. You get into the correctional system, the youth population, the elderly population, you know, across all socioeconomic levels. There's no way we could cover everything that we would like to cover about mental health on this program, but we only have a couple minutes left. Is there anything that we didn't talk about today that you want people to learn more about?
I think that for people who are have any questions about mental health, because certainly there's one of the things we didn't talk about is stigma, and that's one of the main barriers for people to even try and access services. Because if you're having a mental illness, you may not ask, do you ask a friend? Do you confide in a coworker? So stigma is a big issue. Calling the United Way 211, they are a good pipeline for services. So if you can explain your situation, then they can get you connected. There's the Iowa Helpline, I think it's iowahelpline.org. They have a 800 number that can help you get access to services. So if you're in need, there are many different ways to which to access services.
Also, I'm going to say the community, we need the community to become a part of this and decrease stigma. And I'm going to put a plug for a program that Horizons is offering and Abby is now offering, and a couple other providers called Mental Health First Aid. And that is a program to help teach the community about mental health and to help become more integrated in understanding of it.
I think we will and can get to the point where we treat mental health like any other illness and health care issue, but only when we start talking about it in that same sense.
Okay. I am so thankful to have all the panelists here with me today. I'm glad that you joined us for this conversation. I know we didn't tell you probably everything you want to know, but we're glad you were here, and we'll continue the conversation next week. Have a good day.